Come to order. A quorum is present. Without objection, the chair is authorized to declare a recess at any time. Since we are working in a virtual format today, I'd like to go over a few housekeeping items before I proceed. I think we probably all know them, but I must do them. First, if you are experiencing connectivity issues, please make sure you or your staff contact our designated technical support so it can be resolved immediately. Members participating remotely must continue to use the video function for the duration of their participation in the hearing unless they experience connectivity issues or other technical problems that render the member unable to fully participate on camera. It is committee policy that members will remain muted when not recognized, just like turning your microphone on and off during a hearing in person. This is out of courtesy to all members on the committee, and so that background noise does not interfere with another member who is recognized to speak. When you are recognized, you will need to unmute your microphone and pause for a couple of seconds before speaking so that we will be able to hear everything you say. If you wish to be recognized, please raise your hand using the Zoom raise hand function, unmute your microphone, and ask to be recognized. In order to ensure everything members say is captured on the live stream of this hearing, I ask the members to pause for 2 to 3 seconds before beginning to speak. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteranaffairs.hearing@mail.house.gov. It will be uploaded to the committee document repository. Please keep in mind that you will need to refresh the repository page as it does not automatically update. Without objection, members will be recognized in order of seniority for questioning witnesses. This makes it easier for me to make sure all members participating have an opportunity to be recognized. Does any member have a question about the conduct of this hearing with members participating remotely? Seeing none, I will now recognize myself for an opening statement. Good morning, and thank you all for joining us today for the Health Subcommittee's first legislative hearing of the 117th Congress. Today's agenda includes legislation covering a broad array of issues. Each piece of legislation is in response to a serious issue or concern affecting our veterans' health care. As a co-sponsor of several of the bills before the subcommittee today, I am proud of the work being done within this committee and throughout this Congress to preserve and enhance the VA care and services so many veterans utilize, value, and recommend. Women veterans often face a unique set of challenges resulting from a combination of traumatic experiences occurring prior to, during, and after military service that can lead to substance use disorders. For example, women veterans are twice as likely as male veterans to develop post-traumatic stress disorder and serious psychological distress, and 1 out of 4 women veterans report military sexual trauma. Providing mental health care and substance abuse services that are specific to women veterans is important to ensuring that women veterans receive appropriate care. One such program is the Women's Veterans Transitional Residents Utilizing Support and Treatment, that are known as the TRUST program, which has become a model for providing treatment and rehabilitative support to women veterans with drug and alcohol dependency. I had the opportunity to visit the program run by the Jamaica Plain VA Medical Center in Boston in November of 2019. This program is superb. Truly, it was extraordinary. And I have heard from both women veterans and VA providers that there should be more programs like it. That's why I introduced HR 344, the Women's Veterans Trust Act. My bill addresses the growing demand for women-only substance use disorder residential treatment programs nationwide. We must ensure women veterans' mental health needs are met in an environment that is safe and conducive to recovery. The women veterans population is not only growing rapidly, it is also seeing more veterans of reproductive age using VA for their health care. This subcommittee has frequently focused on reproductive health, including examining racial and ethnic disparities in maternal mortality and morbidity. This week is Black Maternal Health Week, and today I'm proud that Representative Underwood's Protecting Moms Who Serve Act and Representative Lawrence's Doula for VA Act aim to improve resources for veterans who choose to become mothers. I know the Pause for Veterans Therapy Act has received a lot of attention, and I want to be absolutely clear that this committee and the full committee support veterans with post-traumatic stress having access to trained mental health service dogs, which the VA already does provide. That said, we have some concerns about the bill. It would force VA to grant money to unaccredited dog training organizations, which would likely then provide untrained dogs to traumatized veterans. There are no data suggesting that untrained dogs are beneficial for those with post-traumatic stress. In terms of trained mental health service dogs, a law was enacted last year through the NDAA directing the Department of Defense to implement a Wounded Warrior service dog program that includes veterans with post-traumatic stress. So this bill would be both duplicative and less beneficial to veterans. I'm very pleased to support HR 2441, the Sergeant Ketchum Rural Veterans Mental Health Act from Congresswoman Axney, which will expand VA's rural mental health program, the RANGE program, by 3 new sites at VA facilities in rural, tribal, and insular areas. This is so critical for those communities. In closing, I look forward to today's conversation, as it is always important to hear the views and concerns of various stakeholders as we craft legislation. Your expertise and input are so valuable to us as we consider what changes need to be made to best help our veterans. Before I recognize General Bergman for his opening statement, I would like to acknowledge Chairman Takano is joining us here today, and I see him in his square. And so thank you, Chairman Takano, for being with us. He will forego, I understand, his opening statement now and save his comments for his bill, the Korean American Valor Act, which is on the agenda today. With that, I'd like to recognize Ranking Member Bergman for 5 minutes for any opening remarks he may wish to make. General Bergman?
Okay, assuming we've successfully unmuted.
Very good.
Thank you, Chairwoman Brownlee. I appreciate being here with you, our colleagues from on and off the committee, and our witnesses from the Departments of Veterans Affairs and the Veteran Service Organizations to discuss the 9 bills on today's agenda. These bills address some of the most important issues facing veterans and the VA healthcare system today, including mental health care, patient safety, maternity care, and recruitment incentives. I look forward to discussing them in detail this morning and to working with my colleagues and stakeholders to improve upon them as they move through this committee and hopefully to the House floor. 3 of the 9 bills on today's agenda are sponsored by my Republican colleagues. I support each of those bills and would like briefly to discuss their importance. The draft bill sponsored by Dr. Winstrip would make a technical correction to current law to ensure that the top podiatrist in the VA healthcare system is on equal footing with the top physician in other specialties. Dr. Winstrip preceded me as the lead Republican on this subcommittee and knows better than anyone the demand for podiatrists is growing among veterans. His bill will make sure that VA's podiatry service is able to meet that demand with timely, quality, best-in-class care. Congressman Mckinley's bill is HR 1510, the Veterans Camera Reporting, or VCR Act. It would require VA to assess the use of cameras in VA medical facilities and make recommendations for improvement. It was written following several high-profile cases across the country, including some in which veterans lost their lives, where missing or malfunctioning security cameras compromised patient safety or failed to provide the adequate evidence in a law enforcement incident. It will help ensure the VA medical facilities are safe for veterans and employees. Finally, Congressman Stiver's bill is H.R. 1448, the Pause for Veterans Therapy Act. It would authorize VA to provide service dogs to veterans with mental health conditions, just like they provide service dogs to veterans with visual or physical impairments. It would also support organizations who are providing service dogs at no cost. And no cost to veterans already, and expanding an existing pilot program in which veterans with PTSD receive residential treatment that includes a service dog training component. It has supported this Congress by more than 300 of our colleagues, including numerous committee members from both sides of the aisle. That groundswell of bipartisan support is in short supply on Capitol Hill these days, but I think we can set the standard here on our committee. It reflects that the groundswell of support for service dogs that has existed in the veteran community for many years. I'm willing to bet that every single member of this subcommittee and each one of our witnesses and audience members has heard of a veteran who believes that their service dog, their trained service dog, not their pet, has helped save their life. And I believe that. At the request of Congress, VA has been studying whether service dogs can help veterans with PTSD for several years. VA released results from that study in January, concluded, and I quote, "Participants paired with a service dog experienced a reduction in severity of PTSD symptoms compared to participants paired with an emotional support dog and had fewer suicidal behaviors and ideations," end quote. This was a tremendously complex study, and I commend VA for seeing it through. The scientists who performed it will say that the finding I just read may be statistically significant, but not clinically significant, and that more research is needed. I support more research, but I also support not letting the perfect be the enemy of the good. We need to move forward. Too many veterans are struggling today. It is unconscionable that we would make them wait for a perfectly designed and executed study before getting them the help they need, especially when we have the evidence right now from VA and from others of an intervention that can demonstrably improve their lives. I appreciate Dr. Smith and Dr. Johnson, who are both with us today from VA, for taking time earlier this week to meet with my subcommittee staff and staff from Congressman Stiver's office to discuss the Pause for Veterans Therapy Act. I understand this was a productive conversation that corrected several misconceptions the department had about the bill. The Pause for Veterans Therapy Act passed the House unanimously last Congress. I'm hopeful we can repeat that achievement again in short order. Veterans are counting on us to get it done. Chairwoman Brownlee, before I yield, I want to say a special welcome to our lead VA witness, Dr. Clifford Smith. He works out of the Oscar G. Johnson VA Medical Center in Iron Mountain, Michigan, up in the Upper Peninsula, and is one of my constituents. And that's a great facility. I need to get you out there so we can see it here. Whether you want to go snowmobiling or fishing or golfing, we can do all three in the same day, depending on the weather, time of year we do it. But I'm very grateful for the work that he does for veterans in the UP, and I appreciate him being here with us virtually today to share his expertise with the subcommittee. Thank you, Dr. Smith. And with that, I yield back.
I have to unmute myself. I've got other people magically muting me, and so I forget. So I apologize. We will now welcome our first panel, where we will hear from colleagues who have sponsored legislation on today's agenda. I'll begin by recognizing Chairman Takano for 3 minutes for any remarks he may wish to make in support of his bill, H.R. 234, the Korean American Valor Act. Mr. Chairman.
Madam Chair, thank you so much for recognizing me. My bill, H.R. 234, the Korean Valor Act, would correct a decades-long gap in VA's Allied Beneficiary Program and begin to rectify significant inequalities between our European and Asian allies living in the United States. For 63 years, veterans of all of Allied forces from World Wars I and II have been able to enroll in VA healthcare. The UK, Australia, France, New Zealand, and Canada have had reciprocal agreements with the United States for reimbursing the VA for care provided to their veterans and vice versa. In the 1970s, Congress also made veterans of the Czech and Polish armed forces who have been American citizens for at least 10 years eligible for VA healthcare. However, neither the Czech Republic nor Poland have reciprocal agreements with the US. So VA is not reimbursed for the care provided to these veterans. Yet still today, veterans of the Republic of Korea who fought alongside us in the Vietnam War and then went on to become citizens of the United States are denied what their European counterparts already have: access to veteran-centric, high-quality care from VA. Over 300,000 Koreans fought alongside the United States in Vietnam. Thousands went on to build lives in the US. Nearly 3,000 of these veterans are now US citizens. Many of these Korean American veterans suffer from significant injuries due to their service, including post-traumatic stress disorder, total disability, and the effects of the toxic defoliant Agent Orange. However, despite their service as our allies in the Korean military, these Korean Americans are not recognized as US veterans in theory or in title, and are not therefore granted access to VA services under law. They are also not covered by the Korean healthcare system while living in the United States. Once they are naturalized US citizens, they are recognized by South Korea as foreign nationals with no benefits available to them in the United States. Mr. Alfred Chung, on behalf of the Korean American Associates of the Vietnam Veterans of America, submitted a statement for today's hearing in which he said, quote, "These Korean American Vietnam War veterans are in a difficult situation. They have been forgotten by both governments. These war veterans are aging and suffering from the twilight of a difficult life, with their families caring for them from the after effects of war." In 2019, 1,022 Allied veterans received care from the VA. And what may surprise some is that 851 of those Allied veterans were under the age of 65. So as long as the veteran has served in the armed forces of a country that was an ally of the United States during the World Wars, they are eligible to receive care at VA. Age and citizenship are not factored in, but the conflict in which your nation was an ally is. 3,000 Korean Vietnam veterans, now Americans, are asking this country to respect their service as fully as we respect the service of our European allies. I want to thank former Congressman Gil Cisneros for introducing this legislation last Congress, and I will continue his efforts to ensure that this bill becomes law. These Korean American veterans just want to be treated fairly, and I say that is the least that this Congress can do. And while I'm disappointed the VA doesn't agree, I hope we can discuss today a path forward to ensure that VA's belief in equity extends to all parts of the enterprise. Thank you, Chairwoman Brownlee. I yield back.
Thank you, Chairman Takano. Congresswoman Underwood, you are now recognized for 3 minutes to deliver remarks in support of your legislation, HR 958, the Protecting Moms Who Serve Act.
Well, thank you, Madam Chair. I'm honored that our subcommittee is considering the Protecting Moms Who Served Act, a bipartisan bill to address maternal mortality among veterans, which I proudly introduced with Chairwoman Brownlee and Representatives Gus Villarakas and Brian Fitzpatrick. The United States is currently confronting a maternal health crisis. We have the highest maternal mortality rate in the developed world and significant disparities for women and birthing people of color. Some of the drivers of adverse maternal health outcomes can be even more prevalent in women who serve. For example, 1 in 3 women veterans report that they experienced military sexual trauma, which is linked with risk factors for pregnancy-related complications. With unacceptable maternal mortality rates for all US mothers and unique risks for veterans, we must ensure that the VA is providing the highest quality maternal health care and support to moms who served. Currently, prenatal and postpartum care covered in the VA medical benefits package is provided in the community, even as pregnant veterans and new moms continue to receive other health services in the VA health system. To coordinate this care, the VA has established maternity care coordination programs, as described in a VHA directive. My bipartisan Protecting Moms Who Served Act would codify the programs in that VHA directive, which include new provisions to offer screenings and treatments to pregnant veterans with mental health conditions, as well as measures to strengthen community partnerships with groups that support new moms. The VA's maternity care coordination programs have been successful in ensuring that veterans can receive high quality, culturally appropriate care and robust support throughout pregnancy, during labor and delivery, and for the full year-long postpartum period and beyond. By codifying and strengthening these programs, veterans will continue to receive the world-class care they have earned. The Protecting Moms Who Served Act would also invest in trainings for community maternity care providers so that nurses, midwives, and physicians caring for pregnant and postpartum veterans understand the unique needs of their veteran patients, particularly related to mental and behavioral health conditions that might have been caused or exacerbated by military service or the transition back to civilian life. These trainings will ensure that veterans receive care that is responsive to the lingering physical and psychological impacts of their service. Finally, my bill would commission the first ever comprehensive study of maternal mortality, morbidity, and racial and ethnic disparities for veterans. By having a complete understanding of the extent to which our nation's maternal health crisis extends to the veteran population, we can develop solutions to improve outcomes and save veterans' lives. Thank you, Madam Chair, for your leadership with me on the Protecting Moms Who Served Act and for including our bill in today's legislative hearing. I urge my colleagues on both sides of the aisle to support this critically important bipartisan legislation, and I yield back.
Thank you, Congresswoman Underwood. And I now will recognize Congressman Jeffries. You are recognized for 3 minutes to deliver a statement in support of your legislation, HR 2093, the Veterans and Family Information Act. Welcome.
Thank you so much, Chairwoman Brownlee and Ranking Member Bergman, for your leadership on behalf of our nation's veterans and for providing me the opportunity to testify today. Today, it's my honor to discuss HR 2093, the Veterans and Family Information Act, a bill that would improve non-English language accessibility for veterans, their families, and caregivers. The Veterans Benefits Administration provides critical information to all veterans about their benefits, service-connected disabilities, home loans, vocational rehabilitation and employment, and military sexual trauma. However, there is no consistency in this information being made available in languages other than English. This not only leads to confusion, but denies veterans of limited English proficiency and their families access to this critical information. It is our duty to support our veterans regardless of whether English is their first language. They all served our country. The VA tracks the growing diversity of our veteran population and different languages those veterans speak. In the most recent survey conducted, minorities comprised of approximately 24% of the total veteran population in the United States, and many of those veterans speak languages other than English. 3.5% of Black or African American veterans speak a language other than English. 56% of Asian American veterans speak a language other than English primarily, and 6.7% of Asian Americans speak English in a very limited capacity. 58% of Hispanic or Latino veterans speak a language other than English. These are statistics that the VA has provided itself. There are over 500,000 foreign-born veterans that live in the US, and additionally, about 1.9 million veterans are US-born children of foreign-born parents. Every single veteran deserves consistent, clear, and equal access to any and all information that the VA can provide regarding resources and benefits that they have access to because of their service to our country. In addition, for veterans who may speak English as a second language, the burden of having to rely on caretakers or family members to understand VA benefits can be a barrier to access services. The delay of translation services can add another layer of difficulty in understanding and being able to live a life with dignity after their service. No veteran should encounter accessing resources in a burdensome way. No veteran should feel like they have less access to information because of challenges with respect to language proficiency after having served our country. It is of the utmost importance that every single veteran and those who care for them are aware and able to immediately and efficiently receive equal access to the resources and care that they might need and have earned. The Veterans and Family Information Act would direct the Department of Veterans Affairs to make versions of all of its fact sheets available in the 10 most commonly spoken languages other than English in the United States, including Spanish and Tagalog. I would like to thank the co-sponsor of this legislation, Representative Young Kim, for her leadership and partnership, as well as all of the distinguished members of the Veterans Committee, including Chairman Takano, Chairwoman Brownlee. Thank you for this opportunity to testify, and I respectfully ask that you support this important legislation.
Thank you, Chairman Jeffries. And this is an extremely important bill. In essence, it's a very simple, straightforward, easy to enact bill, but an extremely important one in terms of equitable access and high quality care for all of our veterans. So, thank you for bringing this forward. And we certainly look forward to making sure it will become law. So thank you very much for that. I see Congressman Stivers here. I recognize Congressman Stivers for 3 minutes to deliver any comments you may have in support of your bill, HR 1448, the Pause for Veterans Therapy Act.
Thank you, Chairwoman Brownlee. I want to thank you and Ranking Member Bergman for holding this legislative hearing today and for giving me the opportunity to discuss a bill that I feel is very personally important, the Pause for Veterans Therapy Act. I'd like to express my deep appreciation to the leadership coalition that's led this bill over the last 2 Congresses, including Representative Rice, Representative Walz, Representative Slotkin, Dunn, Sherrill, and Rutherford. By now, you know the bill creates a pilot program at the VA over a 5-year term. The pilot program is 2-pronged. First, the VA healthcare provider would refer a veteran to a service dog training organization to learn the art and science of dog training. Once the training program is complete for the dog and the veteran, the pair would graduate and remain together for continuing service and therapy. The veteran may also opt out of the remaining with the dog if the veteran or his health provider determine it's not in the best interest of the veteran to remain with the dog. As a Major General with a deployment, I know that the mission ends, but for some, the invisible scars left by war do not heal. Suicide rates among our veterans have remained tragically high and are between 17 and 22 a day, depending on whose metric you believe. There's peer-reviewed science that shows that this therapy works. And I've heard from so many veterans that said they've gotten their life back when they got their dog. From a Vietnam era veteran to those from wars today, including one that was under my command in Iraq, I've heard the difference these dogs makes and how they've given them, the veteran, freedom to go out, to go to dinner, to get on a plane. They've gotten their lives back. You know, our mission in Congress is to care for our veterans and give them every tool they need to succeed. Our colleagues understand this mission, and that's why 313 of our colleagues have co-sponsored this bill as we speak. We can't let veteran suicide go on any longer, and I hope we'll move this bill quickly. It's passed the House twice, and it's time to get it done. There's a bipartisan coalition in the Senate, including Senator Sinema, Senator Tillis, Senator Kramer, and Senator Feinstein, that have introduced companion legislation. We have to help these veterans, and we have to fight against suicide. And veteran dog therapy works, and we need to help these veterans. And I think we can do it through this bill. I hope that you will support HR 1448 and get it passed to the House so we can make it law. Thank you, Madam Chair. I yield back.
Thank you, Congressman Stivers. And, as chair of this subcommittee, I absolutely support the intent of this bill. I think we can get there. I just think we need to work through, a couple of changes, and we're there, and you can have unanimous support in both the House and the Senate. So we will look forward to working with you on that. Congresswoman Axney, you are now recognized for 3 minutes to deliver a statement in support of your bill, HR 2441, the Sergeant Ketchum Rural Veterans Mental Health Act, which you, I understand, introduced earlier this week. So welcome, Congresswoman.
Well, thank you so much, Chairwoman Brownlee and Ranking Member Bergman, for having this really important hearing. And I am proud to discuss this piece of legislation that I hope we can move forward with. I am here today representing Iowa to discuss a bill I introduced with my fellow Iowa representatives, including Congresswoman Miller Meeks, who serves on this committee. 5 years ago, retired Sergeant Brandon Ketchum took his life after he was unable to get the mental health support that he needed. Brandon was a Marine. He served on 2 tours in Iraq and a tour in Afghanistan. And while on his first tour in 2006, he helped clear 92 roadside bombs in 7 months. That service earned him a Combat Action Ribbon. But like so many of his fellow veterans, Sergeant Ketchum struggled with addiction, depression, and PTSD related to his time in uniform. And when he sought inpatient hospitalization in 2016 from an Iowa VA, the treatment rooms were all full and he was denied inpatient treatment. Hours later, Sergeant Ketchum took his life. Recently, I spoke with Brandon's mom, Bev, about Congress's need to do more support for our veterans when they return home. We don't have enough adequate mental health services across this country for our veterans. An HHS study found that 50% of returning vets who need mental health treatment will receive it. These mental health services are even harder to find in rural parts of our country, like Iowa. So my bill would increase the available mental health facilities in rural areas by establishing the new Rural Access Network for Growth Enhancement Programs, known by the acronym RANGE. RANGE programs provide rural veterans with mental illness access to a team of experts who can help them reintegrate into their community. RANGE experts also can include existing family and financial resources to help with the recovery process. My bill will also study how the VA is currently meeting the needs of rural veterans with mental health issues and what resources may be needed to improve care so that when veterans ask for treatment, they aren't turned away. It's so important that we work to ensure what happened to Sergeant Ketchum never happens to another veteran. Veterans put their lives on the line to serve our nation with honor, and when they come home, they should be able to receive the care that they need, regardless of the zip code that they live in. We cannot allow stories like Brandon's to be repeated. We must take action to address rural health shortages and mental health needs of our nation's veterans. Thank you for allowing me to be here today, and I respectfully ask you to support this bill. Thank you, and I yield back.
Thank you, Congresswoman, and thank you for your work on this important legislation, and really to also honor the memory of an Iowa veteran who did not get the timely mental health care he needed and he deserved. So this is an extraordinarily important bill for rural America, insular, tribal areas where the mental health care is not, it's simply just not up to snuff, and we've got to approve upon it. So thank you for working really hard on this issue. Next, we will welcome Congresswoman Lawrence. You are recognized for 3 minutes of remarks on your draft bill, the Doula for VA Act. Welcome, Congresswoman.
Thank you so much. Thank you to Chairwoman Brownlee and Ranking Member Berman. I was proud to introduce the legislation in partnership with the leaders of the Bipartisan Women's Caucus to provide increased access for doula care for veterans. This bipartisan legislation would establish a pilot program to encourage the use of doulas in the Veterans Health Administration to support pregnant veterans and improve maternal health outcomes. Increasingly, women veterans have been relying on the Veterans Health Administration for maternal health services. Pregnant veterans have found to be disproportionately impacted by mental health disorders. So we must ensure that they are afforded adequate support to prevent childbirth complications. Research has demonstrated that expectant mothers are more likely to have positive birth outcomes when provided with the support of a doula than those without. This legislation requires the Department of Veterans Affairs to establish a pilot program to provide the doula support and measure the impact these services have on pregnant veterans, child care, mental health, and infant care outcome. It also improves the experience of veterans receiving maternal care from the department, including the ability to develop and follow their own birthing plan. The pilot would be developed through consultation with stakeholders, including veterans organizations, community-based healthcare professionals such as doulas, and experts in promoting health equity and combating racial bias in healthcare settings. Again, let me re-emphasize that the goals of the pilot program are to improve maternal, mental, and infant healthcare outcomes, the integration of doula support programs into the whole health model of the department, the experience of women receiving maternity care, including by increasing the ability of women to develop and follow her own birthing plan. I thank you for this time to introduce and let you know about my bill, and I yield back.
Thank you, Congresswoman Lawrence. Thank you for working on another important issue for women's health. And before I move on, if any members of the subcommittee would like to comment on any of the bills, the time is now. Otherwise, we will move on to the second panel. I don't think I see any hands raised. Oh, Congressman Moran, you're recognized.
I thank you very much, Chairwoman Brownlee. I want to thank you for the opportunity to speak about my draft piece of legislation that would establish the VA pediatric medical director with Dr. Winstrup. I am proud to have joined Dr. Winstrup as a lead sponsor of legislation to establish a VA pediatric medical director. I wish to emphasize that this legislation is meant to correct a technical error and is consistent with the intent of the VA Mission Act, which was signed into law in 2018. One of my top priorities as a member of Congress is to ensure our veterans receive quality health care, including pediatric services. And I know that mission is shared by each and every member of this subcommittee, pediatric. To achieve that goal, we must enable VA to recruit the best talent to its provider workforce. I am grateful that a discussion draft has been included in today's legislative hearing, and I look forward to working with my colleagues to pass this critical legislation. I thank the committee for this opportunity and the importance of the pediatric director within the VA. It is a clerical error, and I respectfully ask for the committee's support on this piece of legislation.
Thank you, Congressman Moran, and appreciate that since Dr. Winstrup was not able to be here. And seeing no other members who wish to speak, I would like to move on and introduce our second panel. We have joining us representatives from 3 veteran service organizations, Mr. Marquis Bearfield, the Assistant National Legislative Director of Disabled American Veterans, Mr. Brian Dempsey, the Government Affairs Director of the Wounded Warrior Project, and Ms. Lindsay Church, Executive Director and co-founder of Minority Veterans of America. We appreciate all of you for being here today, and I will remind our witnesses to please pause for 2 to 3 seconds before speaking so that the recording will capture all of your words, and please remember to do so when answering members' questions. Your written statements in full will be included in the hearing record without objection. Mr. Bearfield, we'll begin with you. You are now recognized for 5 minutes for remarks on the bills before us. Welcome.
Thank you, Chairwoman Brownlee. Chairwoman Brownlee, Ranking Member Bergman, and members of the subcommittee. Thank you for inviting DAV to testify at this legislative hearing. DAV is pleased to offer our views on the bills under consideration by the subcommittee. DAV strongly supports the Sergeant Ketchum Rural Mental Health Act. This bill seeks to enhance VA mental health resources and make program improvements to better meet the needs of veterans with serious mental illness who live in rural communities. This bill would establish 3 new centers for implementing the RANGE program. The RANGE program provides an intensive level of services with an emphasis on recovery for rural veterans with serious mental illness who are experiencing homelessness or who are at the risk of becoming homeless. Veterans in the RANGE program had high rates of overall satisfaction with VA mental health services. This bill would expand the effective program in rural communities. Another bill that DAV strongly supports is HR 344, the Trust Act. Women veterans face a unique set of challenges associated with their military service that elevates their risk for developing substance use disorders, to include post-traumatic stress disorder related to combat and military sexual trauma. It is estimated 1 in 4 women veterans accessing VA healthcare engages in unhealthy alcohol use. The number of women veterans admitted to substance use treatment programs is rising. Given these findings, DAV believes the study required in HR 344 aimed at understanding the need for gender-tailored substance use disorder treatment programs is warranted. DAV is also pleased to support HR 958, the Protecting Moms Who Served Act. This bill will require the VA to increase support for its maternity care coordination activities and identify any adverse effects military service has on maternal, mortality, and morbidity among women veterans. With a specific focus on racial and ethnic women veteran minorities who utilize VA healthcare services. Because maternity services for women veterans are provided through VA's community care network, maternity care coordinators play a key role in ensuring women veterans receive high quality care. Maternity care coordination programs are linked to improve health outcomes, but unfortunately, many VA facilities lack a dedicated full-time maternity care coordinator. HR 958 would help to address this issue. Likewise, we are pleased to support the draft measure to establish a pilot doula program in VA. This draft bill would provide pregnant and postpartum women veterans access to doula services in an effort to foster better child and maternal health outcomes. Doulas act as advocates before, during, and after pregnancy, helping expectant and new mothers navigate their birth experiences. Establishing doula service coordinators would aid coordination of care between VA and community providers and could help to improve poor maternal health outcomes. Although DAV has no specific resolution related to HR 2093, the Veterans and Families Information Act, we see the benefit of this bill and have no objection to its passage. Language is often a barrier for minority veterans seeking VA benefits and health services and can impede their ability to understand and apply for earned benefits and negatively impact the effectiveness of their care, as well as healthcare outcomes. Requiring VA to print fact sheets about healthcare services and benefits in the 10 most commonly spoken languages would help to resolve this issue. Likewise, DAV does not have a specific resolution calling for a report on video camera use at VA medical facilities as prescribed in HR 1510. This legislation would help VA determine best practices for ensuring patient and employee safety at VA healthcare facilities. For these reasons, we have no objection to the subcommittee's favorable consideration of this bill. Finally, Madam Chair, DAV does not oppose a pilot program as outlined in the PAWS Act. However, we do have a few recommendations. DAV would like to see the inconsistencies between the federal statute and regulations regarding eligibility for service dogs and veterinary insurance resolved. Also, the bill should require the use of an accredited service dog training organization accepted by VA. Lastly, legislation was enacted last year requiring DoD to establish a Wounded Warrior Service Dog program for service members and veterans. Madam Chair, this concludes my remarks, and I welcome any questions that you or members of the subcommittee may have.
Thank you, Mr. Bearfield, and we always appreciate you and DAV's input into these bills. So thank you so much for your participation. Next, I'd like to recognize Mr. Dempsey for the Wounded Warriors Project's testimony. Mr. Dempsey, welcome.
Thank you. Chairwoman Brownlee, Ranking Member Bergman, and distinguished Health Subcommittee members, thank you for inviting Wounded Warrior Project to testify at this morning's hearing to discuss legislation intended to improve VA's ability to provide better access to care and ensure better health outcomes for our nation's veterans. Honoring and empowering Wounded Warriors has been at the heart of Wounded Warrior Project's mission since 2003. Meeting the needs of the wounded, ill, and injured veterans who volunteered to serve our nation and protect the freedoms we enjoy as Americans is not only a solemn obligation, but a national priority. The written testimony you've received reflects Wounded Warrior Project views on each of the bills before you, but for this morning's hearing, I will focus on those that would advance our efforts in support of women veterans and rural veterans, and which are particularly helpful in building a better, smoother experience for those who depend on VA to meet their healthcare needs. To begin, I wish to clearly state our support for the Protecting Moms Who Served Act and the Women Veterans Transitional Residence Utilizing Support and Treatment Act, also known as the Women Veterans Trust Act. We commend you, Chairwoman Brownlee and Representative Underwood, for championing these bills, as well as your colleagues who serve on the Women Veterans Task Force who have made advocacy for women veterans a top priority for Congress. We don't offer any specific improvements for either bill, but rather wish to emphasize that they would be filling gaps in service or certainty where they currently exist, and building research to drive future improvements to care. Regarding the Trust Act, this bill is consistent with work our organization did in collaboration with RAND that looked at the shortcomings of care available to post 9/11 veterans with co-occurring substance use and mental health disorders. While the Trust Act addresses substance use disorders specifically, we can still attest that 43% of women who completed our annual survey screened positive for risky drinking behavior. This is a primary reason for our concern, but beyond that, VA's 2020 National Suicide Prevention Annual Report shows that suicide rates among VHA users with a substance use disorder are higher than those with PTSD, anxiety, and depression. The Trust Act would encourage improvements to substance use disorder treatment options catered specifically to women, most notably in long-term residential settings, and this is a key step towards modernizing VA care in response to changing demographics. As to the Protecting Moms Who Served Act, for women who use VA healthcare to depend on it to meet all of their health needs, we have an obligation to build a system that accommodates and prepares for the care that's needed. VA must be prepared to serve its increasingly diverse population of veterans during every stage of their life, including on their journey to motherhood. VA's maternity care coordination program, which this bill focuses on, is absolutely essential for women veterans who choose to become mothers. It serves the important purpose of ensuring that the maternity care a woman veteran receives in the community is delivered seamlessly and in lockstep with the rest of her VA care plan. By codifying and investing in this program, Congress would be safeguarding it for all veteran mothers. The next bill I want to emphasize support for is the Sergeant Brandon Ketchum Rural Veterans Mental Health Care Act. The bill would address what continues to be a major concern of ours, which is access to care for those who live outside urban areas. 57% of Wounded Warrior Project alumni live in rural areas, and among that group, 32% selected lack of resources in their geographic area as a reason they had difficulty accessing mental health care, which was 12% higher than their urban peers. The gap was even more pronounced for women specifically, as 42% in rural areas cited geographic issues compared to just 20% of women in urban areas. The Sergeant Brandon Ketchum Rural Veterans Mental Health Care Act would expand VA's range program to 3 new rural locations and ensure closer proximity to care that includes community-based intensive clinical case management and psychotherapy services for rural veterans diagnosed with chronic severe mental health issues. We don't offer any suggestions for improvements at this time, other than to say that rural veterans would benefit from more access points than this bill would provide. To that end, we are grateful that the bill includes a reporting requirement that would help Congress and VA pursue those steps with more evidence and data. We thank Representative Axney for getting this conversation started and for recruiting the full Iowa delegation to the cause. We hope that others on the committee will join as well. Ladies and gentlemen, it is my distinct honor to be here to represent our nation's wounded warriors and their families. I appreciate the opportunity to highlight these important issues and those outlined in our written testimony in order to help Congress assist VA provide better access to care and ensure better health outcomes for our nation's veterans. Thank you, and I stand ready to answer any questions the committee may have.
Thank you, Mr. Dempsey. And I just want to say that the subcommittee and the full committee, the full VA committee, is extraordinarily grateful for, particularly for everything that Wounded Warriors does and across the country, but particularly grateful for the survey you've done on women veterans. It's given us a tremendous amount of new insight and will be a very important part of the Women's Veterans Task Force work moving ahead in the 117th Congress. So I want to thank you for that. And now we'll hear from Ms. Church from the Minority Veterans of America. So I understand it's your birthday. Happy birthday, and please proceed.
Thank you, ma'am. Chairman Takano, Chairwoman Brownlee, Ranking Member Bergman, and members of the committee. My name is Lindsay Church, Executive Director and co-founder of Minority Veterans of America. We work to create belonging and advance equity and justice for thousands of members and advocate for the needs of over 9.7 million minority veterans. Thank you for the opportunity to provide inputs on their behalf. A full list of our positions on the bills before the subcommittee can be found in our written testimony, but there are a few I want to expressly mention and urge swift passage of this morning. First, the Women Veterans Trust Act. We are in desperate need of programs and continued research focused on gender-specific care and its reduction capabilities on actual and perceived barriers to treatment. There is established precedent that such care improves overall patient outcomes. Our nation's women veterans that do have access to gender-specific mental health care are twice as likely to report having their healthcare needs met, with women of color reporting the greatest perceived outcomes. Despite efforts to increase screening for mental health conditions, many veterans living with traumatic effects of post-traumatic stress and military sexual trauma symptoms do not seek mental health care due to its widespread stigmatization and a disenfranchisement with the ill-informed support structures that disregard or criminalize their lived experiences. To cope with symptoms, many self-medicate using illicit substances and alcohol in lieu of professional care. Current frameworks of understanding mental health and coping mechanisms make these expressions incomprehensible and are often criminalized. In addition to the bill's provisions, we recommend that screening for alcohol use disorder be tailored by gender. Multiple VA studies indicate current screening protocols may be insufficient to accurately assess and identify alcohol use disorder among women veterans. Specifically, VA standards in use were developed based on male drinking patterns. It has been shown that gender-tailored screening could increase identification of alcohol use disorder among women veterans by 15%. These frameworks are a precursor for treatment, and these gender-neutral standards are attributed to male veterans receiving associated care at a rate 3 times higher than women veterans, despite a similar prevalence of alcohol use disorder. Additionally, we recommend that significant attention and support be placed on post-treatment outcomes and support structures, including supportive services like housing placement and group treatment therapy. Provision of aftercare support will help to curtail potential relapses and reduce the continuum of harm felt by women veterans. I would next like to mention the Protecting Moms Who Served Act. This bill would require VHA to research and report on discrepancies in pregnancy-related medical care and overall health based on their idiosyncratic identities and orientations. It's the type of intersectional and comprehensive legislation that we have and will continue to advocate for when crafting bills in the future. There continue to be many reported instances of blatant discrimination by medical professionals for expecting parents in same-sex and same-gender couplings. This is frankly unacceptable. As a nation, we are charged with serving those that have selflessly served, and this body has made it clear that that support and care comes without regard to a family's sexual orientations or gender identities. We must do better. I applaud the efforts in this bill that would allow us to do so. Pregnancy-related mortality has been increasing since 1987, and Black and Indigenous parents are more than 3 times as likely to die of pregnancy-related complications when compared to their white counterparts. 3 in 5 of these deaths were deemed preventable by industry professionals. That mortality rate increases drastically in expecting parents older than 35, affecting much of the veteran population. Identification and understanding of personal and systemic factors causing pregnancy-related mortality disparities can guide the prevention strategies required to reduce them. One such proven strategy is the utilization of doula services, which would be afforded with the passage of the Doula for VA Act of 2020. Recent studies indicate that birthing parents who use doula services were 4 times less likely to experience a low birth weight and 2 times less likely to experience other birth complications. Doulas can provide the needed advocacy and support for those that are at greater risk for bias and discrimination, and otherwise make significant impact in our fight for equitable outcomes, especially for Black and Indigenous veterans. We are grateful for this committee's work to address some of the deepest inequities and injustices veterans, especially minority veterans, face. Our feedback echoes the experiences of many who have been excluded or underserved through VA care programs, whether intentionally or negligently. As a country, we have made great progress in ensuring all veterans benefit from the supportive services of the Department of Veterans Affairs, and I look forward to continuing that trend. And again, thank you for the opportunity to testify today, and I'm happy to answer any questions you have.
Thank you, Ms. Church. I appreciate, again, you being here, and also appreciate your organization's input into this legislation. So I'm eager to jump into the questions. I'm reminding everybody the 2 to 3 minute pause rule. And I will now recognize myself for 5 minutes for questions. And Ms. Church, I'm gonna ask the birthday girl first a question. I appreciate the statements that you made about the residential treatment programs for women veterans, and you actually provided some additional recommendations. So, I would just like you to, say out loud and for the cameras and for the audience that why are women only substance use disorder and trauma treatment programs essential? And how do you sort of envision the expansion of these programs?
Thank you for the question, ma'am. We've long since advocated for programs that are built specifically for communities and not tailored after the fact. What we're really excited about with this is the opportunity to build, and much like we talked about with the alcohol use disorder identification and treatment, looking at how we can actually build these programs with women veterans in mind first, and not building programs that are male specific and then later on adapted for women. The expansion and the availability of this is dismal across the country, for one. And there are many veterans, women veterans, who are looking for this treatment, these types of treatment facilities because of their unique traumas. Military sexual trauma and women who have experienced military sexual trauma are in a mixed gender facility or treatment program are more likely to experience those trauma triggers on a regular basis and not be able to actually focus on their care. So we're really excited about the expansion of gender-specific care across the board, but really look forward to the opportunity to continue in the mental health space.
Thank you very much. I mean, I wish we could actually get some real feedback from patients who have been in the current programs within the VA, the residential programs, where they might share a couple of beds in a large treatment center, predominantly with men, and to sort of get their feedback. But thank you very much for your testimony. So, Mr. Bearfield, you also, I think for Mr. Bearfield and Ms. Church, I think I want to talk a little bit more about the pause of Veteran Therapy Act, and ask both of you. I noticed that both of you sort of share some of my concerns around that act, and I'll just ask you a very direct question in that, would you support language that instead extends the existing veterinary insurance benefit to veterans with post-traumatic stress who are referred for service dogs, and secondarily clarifies in regulation that a veteran with post-traumatic stress does not need to also have a mobility impairment to be referred for a service dog? So if both of you could comment on that.
Thank you for the question, Chairwoman Brownlee. And the short answer would be, if the way the bill is written now, if it reflected the statement that you just made, then the short answer would be yes on both situations.
And yes, ma'am. From our perspective, much like Mr. Barfield, we would agree. And the provision of insurance for many minority veterans who are socioeconomically insecure, this provision would allow them the opportunity to not have to pay those same out-of-pocket costs, and would actually reduce their financial need, which we absolutely advocate for.
Great. And Mr. Dempsey, can you comment on this particular bill and maybe give us a little insight into the at least your perspective of the first phase of the VA study was, and comment on that?
Absolutely, and thank you, Madam Chairwoman, for the question. I think I would start just by emphasizing that it's long been Wounded Warrior Project's position that mental health treatment should be grounded in evidence-based therapy and make room for complementary and alternative therapies when appropriate. And we've looked at just how training service dogs can fit into that. So looking at the work therapy program that the Pause for Veterans Therapy Act would provide, we've seen many, evidence from the field through partnerships that, it does provide a great benefit, but we do want to take good care to ensure that we're speaking specifically to service dogs, which are distinct from emotional support animals. The VA study does go through, comparison of the two, and, shows that service dogs actually provide some greater benefit, but just want to make sure that the, anything that is passed ensures proper distinction there, because there is a difference.
Thank you so much for that. We will now, I will now recognize General Bergman for 5 minutes of questions. General, the floor is yours.
Thank you, Chairwoman. It's going to be kind of rapid fire for all of you, so I'll try to keep the questions short. You keep your answers short, and we'll move on. How's that? Mr. Dempsey, thank you for your support of HR 1448, the Pause Act. Why do you think that increasing access to service dogs for veterans with mental health conditions is so important?
Thank you, Ranking Member Bergman. There's evidence to support the fact that these highly trained service dogs can provide great benefit to veterans living with PTSD, even more importantly, severe PTSD. There absolutely is, there are critical duties that these dogs perform that can relieve symptoms of PTSD, like providing nightmare and anxiety interruption, turning on light switches, standing next to their handler to provide personal space in crowds, and entering space first to ensure that there's no threats present. And to be, again, very clear, service dogs are, a defined and protected class under the Americans with Disability Act. And it's that training, exhaustive training, that makes them so helpful. And again, to the work therapy aspect of it, many warriors have reported that this work therapy helps them feel purposeful, makes a difference in their mood, and relieves some of their anxiety and depression. So we like both of the functional parts of that bill.
Good, thank you very much. Mr. Bearfield, regarding HR 344, the Women's Veterans Trust Act. The VA will testify on our next panel that there is sufficient mental health residential capacity for women veterans. Do you agree or disagree, or why not?
When it comes down to HR 344, Ranking Member Bergman, substance use disorder for women veterans has an increased risk of suicide. It's noted that 30% of suicides completed were due to drug and alcohol use. So there has to be something done to help increase the services that women veterans need to address this particular issue. So more can be done to help women veterans in this particular arena.
Okay, thank you. Ms. Church, regarding HR 958, Protecting Moms Who Served Act, do you hear significant concern from your women veteran members about the maternity care services they are offered from VA? And if so, what are the most important concerns that you hear?
Thank you for the question, sir. To be frank, we don't hear a lot of conversation about VA's maternal care, mostly because women veterans don't know it exists and they don't have the access that they should. We, for a long time, have not been really talking about this. I know when I first moved to Richmond, it was the first time I literally had ever heard of maternal care at VA, and that was in 2019. So we don't often hear, and we would love for that to change, that VA is this primary service provider of the whole veteran's health.
Okay, so the point is get the messaging out. Also,
Yep.
Ms. Church, regarding the Sergeant Ketchum Rural Veterans Mental Health Act of 2021, do we have any data on the number of minority veterans residing in rural, and highly rural or remote areas, depending on how you call it, and specific barriers that they might face in accessing care? If so, what does the data tell you? What does the data tell us? And if not, will you work with our Republican subcommittee staff to figure out how to get the information?
Thank you for that question, sir. And our focus primarily has been on insular and tribal communities where access has been disparate. The access, and what I'm excited about with this particular legislation is that it does include insular communities and it does include tribal communities, which have a high concentration of veterans. And so I think the expansion of programs to those communities and looking more deeply at those infrastructures, especially on the island communities, needs to happen. And that we don't have data on rural folks, but we do have data on tribal and insular folks.
Okay. Mr. Dempsey, if you would please elaborate on the finding regarding substance abuse use in Wounded Warrior Project's most recent survey. Did the survey assess veterans' willingness to engage in treatment to address substance abuse or barriers, such as a lack of gender-specific services that those veterans had experienced? If so, why or why not?
Thank you, Ranking Member Bergman. It did not address that question specifically, but we'd be happy to go back and look specifically at some of the data a bit more closely, see if we can more accurately answer that question for you.
Okay. Thank you. And Chairwoman, I see my time has expired. There's nothing to yield back, but I'll turn it over to you.
Oh, I'm muted. I apologize again. Chairman Takano, you're now recognized for 5 minutes of questions.
Thank you, Chairwoman Brownlee. I have a huge screen here and I sometimes have trouble finding where the mute button is. But thank you. I begin my questioning with Ms. Church related to my Korean Valor Act. I want to thank you for your support of the Korean Valor Act. I assume you've had a chance to read VA's written testimony on the bill and their concerns about the cost of including 3,000 allies in a program that is for allies. What do you think about VA's cost concerns?
Thank you for the question, sir. I hear the concerns and understand that budgetary constraints are a real part of this process. And I do believe that this is a moral imperative for us to provide this care. The costs associated with it are considerably lower than some of the other provisions that we provide to our service members, and arguably are just as important, if not more.
So you don't see this as a reason, their cost concerns are not a reason to deny veterans care. You see a moral reason to actually move forward.
Absolutely, sir. And precedent exists for this to be extended to our allied forces. And so the precedent exists, and the costs should not be the reason why we do not provide this care.
Why is it important that these elderly veterans be treated fairly with our European allies?
Sir, my deepest concern is why Korean veterans are not being considered when it comes to this, to the provision of care when it comes to our allies. In my mind, if we are fighting with allies, if allies are being covered, that we absolutely should cover Korean Americans as well. There's no reason in my mind for why we wouldn't. This wouldn't be a moral imperative.
Well, thank you. I thank you for that, Ms. Church. I want to move on to Mr. Bearfield. Mr. Bearfield, on a different subject, the question is on Cindy Axney's bill, Congressman Axney's bill, that would create more of VA's specialized intensive rural mental health programs. I'm really interested in working with VA and other government agencies, my colleagues, leading other congressional committees and stakeholders in the veteran and medical space to increase the number of clinical providers training, as well as serving veterans in rural locations. I was just on the call with Dr. Clancy yesterday. She says that no advanced country has been successful in getting providers into rural areas. I'm really concerned about getting medical residencies into these areas, providers, psychiatrists, and not just psychiatrists, but also mental health providers. What do you have a response to, this commitment of mine?
Thank you for the question, Chairman Takano. There was some information that I read a while back that noted that the VA was studying what certain VISN directors were doing in order to retain their mental health physicians on their staffs, and that they were going to look at what incentives that those VISN directors were doing to be able to retain those particular mental health providers. So I think once they take a look at that information, they can use that to help recruit and keep staffed mental health providers in rural communities. That way, the need for the additional providers can be there, and they can meet the needs of the rural veterans that need the assistance.
Well, thank you. Is DAV working on provider training issues at all?
You mean specifically for helping VA recruit mental health providers? Is that your question?
Yes, and in particular related to the rural areas as well.
Well, we take into account what our members let us know what the needs are in their particular areas, and then we do relay that to our counterparts that we work with in the VA to let them know that there are serious concerns in those particular areas. So yes, we listen to our membership, what their needs are, and we make sure that we have those conversations with members of the subcommittee here to make sure that those needs are addressed.
Well, I really want to work with DAV to gather more ideas, to get more clinicians competent to serve veterans, especially in the area of mental health. I really want to pick people's brains. I think we have an opportunity to try and expand the universe of mental health providers, especially in rural areas. In particular, how do we get them into rural areas? We can have this debate over choice, but there's no meaningful choice in these, whether it's inside VA or outside of VA. There's no choice. So anyway, I understand that I'm taking over the meeting, so I got to yield back to myself. Let's see. The next Ms. Rattawagon, I call on you for 5 minutes.
Talofa lava. Good morning, Chairman Takano, and
Talofa.
Thanks to Chairwoman Brownlee and Ranking Member Bergman for holding this hearing on these bills. And welcome to all of our guests for testifying this morning. My questions are about the Women Veterans Trust Act. Ms. Church, can you please elaborate on why access to gender-specific care is important and the differences in utilization, demand, and outcomes that it yields?
Thank you for the question, ma'am. As a gender diverse person myself, I can tell you that the bond that's formed between a client and their patient is one of the most important bonds and relationships that a person can have. For me, I prefer women providers, and actually will largely shut down when it comes to a male provider when I don't have the option. And this is the experience of many women veterans and gender diverse veterans and transgender veterans, folks who really truly are looking for that client bond to save their lives. And so I think it's absolutely imperative that we create more gender specific care that is trauma informed and looks at the unique needs of those women veterans. I can get back to you on utilization rates. My staff can follow up some reports and some information on data and statistics around utilization rates.
Thank you, Ms. Church. And as a follow-up, do the women veterans that you engage with believe that VA has sufficient gender-specific mental health care services? Why or why not?
Thank you again for the question. And no, ma'am. Many people are still struggling, especially in the pandemic, to find access to care at all. And to find access to any type of specific care is nearly impossible. We have people that have been waiting 6 months to try to get into VA for mental health care, even if it's virtual. And that's just to get a baseline appointment. So At every level, there is not enough care for mental health for our veterans. But when it comes to that gender specific care, there just is not enough folks, or not enough folks that are trained and qualified in a trauma informed way to provide that care.
Thank you, Mr. Chairman. I yield my time.
Thank you, Ms. Radwagen. I now call on Mr. Sablon for 5 minutes.
Yeah, thank you very much, Mr. Chairman. I have a general question for Mr. Bearfield, Mr. Dempsey, Ms. Church. Thank you. Well, thank you all for joining us this morning. And I want to thank you for your service, for all that you do to improve the life of veterans and their families. Of course, your organizations have been successful at getting veterans involved at the national level to increase the benefits and services. In my district, the Northern Mariana Islands, veterans infrequently benefit from these services because of the limited VA services in our islands and our remote location. And I continue to encourage my veterans to formally organize to advocate for equitable treatment. So my question is, do you have any recommendations or resources to help them become an effective voice for their community, especially involving mental health issues? The one thing that we're really almost entirely lacking. Could my veterans reach out to you and seek your help, despite that they are not members of your organizations? The only VSO in the Northern Marianas is the Veterans for Foreign Wars.
Thank you for that question, sir.
Church, thank you.
Thank you for your question and for your concern for the care of folks, especially on the Mariana Islands. We have several members that are from the Marianas and Saipan, and so one, encourage them to join MVA. We would absolutely love to have them and to advocate for those unique needs. As I mentioned earlier, the care and availability of treatment on a broad, wide scale level on folks that live in insular communities is dismal. Folks traveling from one island to the other and maybe getting care, and it's barely care at that. So one, would love to hear more from them. If you have folks, please send them our way. And two, would love for the committee to really prioritize those needs of folks living on island communities. There's a lot of concern and care for tribal communities, which is amazing, and we are absolutely here for that. And when it comes to island communities, I feel like they are absolutely left behind when it comes to the provision of their care. So I highly encourage this committee and the entire committee to focus on this.
Wow, and I'm outstanding that you actually have some connection with veterans in my district. And I don't know what rules allow, but if you would reach out to them and ask them if they could organize and meet with me, I would really appreciate that, Ms. Church, and thank you for what you do. Mr. Bearfield, Mr. Dempsey, any thoughts?
Yes, I would just echo the sentiments of Ms. Church that yes, if you have constituents in your area that are looking for available services to help them with the Department of Veterans Affairs, by all means, they can feel free to reach out to DAV, and we can do what we can to help them establish their claims or look into healthcare, like as you mentioned, specifically mental health care for them specifically. And we would be more than willing to, see what we can do to help them out with their claims and answering their questions.
Okay, thank you. Because VFW just announced that they're now willing to take provide training for individuals virtually so that they could help other veterans, and that would be something also that I now started to promote in my district. Let veterans know that hey, you can take this training lessons on virtual. And where it was previously required in person, but now you can take it virtual and learn how to assist other veterans. I have very little time left for Mr. Bearfield if he has anything to say.
Mr. Sablon, I understand that Mr. Bearfield's
No.
The other witness, I'm sorry, not Mr. Bearfield, but the other witness is.
Mr. Dempsey.
Oh, okay, so you're Mr. Bearfield and the other one's Mr. Dempsey. Okay, but my time is up almost. So thank you very much again. This is a good hearing. Chairman Takano, I need to exit and join.
Mr. Sablon, if you want to ask Mr. Dempsey a question, I will allow it since Mr. Dempsey's internet went down. Do you have a question for Mr. Dempsey?
Nothing, just a comment on services he provides to veterans. If my veterans, they're not members of his organization, could reach out, and for now, while I encourage them to be members. So, and I'm surprised Ms. Church has members from the Marianas. I'd really like to get to commit and get to meet with them and actually share their thoughts on what I could do for them while I'm in this committee. But no, Chairman Takano, I very much thank you for your generous offer, sir.
You're back. Well, yeah, thank you. And Ms. Church does say that she has members in the insular areas. So I now want to move on to recognize Dr. Miller Meeks for 5 minutes. Dr. Miller Meeks, you have the floor.
Thank you so much, Chair Takano. Thank you, Chairman Brownlee and Ranking Member Bergman as well. I want to thank my colleague from Iowa, Congresswoman Cindy Axne, for testifying in support of her bipartisan legislation, H.R. 2441, the Sergeant Ketchum Rural Veterans Mental Health Act. I'm proud to be an original co-sponsor of this legislation, and I want to thank my colleagues on the subcommittee for holding a hearing on this important bill. Our bill takes important steps to provide rural veterans with more resources by creating 3 new range program centers and requiring the GAO to study whether the VA has sufficient resources to provide mental health care to rural veterans. This bipartisan legislation is named after Sergeant Brandon Ketchum, a veteran from Davenport, Iowa, which is in my congressional district, who died by suicide in 2016. Tragically, stories like Sergeant Ketchum's are far too common, and our country still has a long way to go to address the root causes of veteran suicide. I'm hopeful that our bill will help provide the mental health care and resources and support our service members in rural areas need. Mr. Dempsey, can you speak to the unique challenges that rural veterans face and how range programs at the VA address those challenges?
Thank you, Representative Miller-Meeks. I appreciate the question, and again, wish to reaffirm our support for the Sergeant Ketchum legislation. We take great care to better learn about the warriors who reach out to Wounded Warrior Project for services and programs, and in particular, trying to get to better understand the 57% of our alumni who are based in rural areas. Having, telehealth and having, virtual access to programming has been extremely helpful in the year 2020, but we're also well aware that access and proximity to care is an issue for many veterans living in rural areas. We think that expansion of the range program will absolutely bring that care closer to some. We want to be able to connect, to more, obviously, as I said in my oral statement and in our written statement as well. It is nice that VA is being able to expand its network of care through the community care network. But we also believe that VA needs to expand its capacity too. It's an important coordinator of that care, and want to make sure that we're doing as much as we can to connect veterans wherever they live with the resources and care that they need. Thank you.
Thank you very much for your answer. I know as a commissioner of the Wapello County Board of Veterans Affairs in my home county and a 24-year military veteran, this is a topic that's extraordinarily important to all of us. We want to make sure that our heroes that have signed on the line, raised their right hand and sworn an oath to our country to protect it and defend it, that we're also giving them the care that they need. Veteran suicide is still relatively high, and we know that providing the care services in rural areas, having the access that is timely and needed, especially in emergencies, and then finding meaningful employment and supports for both the veteran and their service members are greatly needed. So thank you so much for your efforts on that behalf, and fully support seeing that the Thank you very much. I was muted. I thought I had unmuted, but I just want to thank you for what you're doing. Look forward to seeing HR 2441 passed into law. Taking care of our veterans is the most important thing that we do. As a 24-year military veteran myself and still a commissioner on my county board of Veterans Affairs, we know that veteran suicide is still too high, and any efforts that we can make to reduce veteran suicide and get care to them in their local areas in a timely fashion is most appreciated. So thank you, Chair Takano. I yield back my time.
Thank you, Congresswoman Miller Meeks. I think I'm going to take over again. Thank you, Chairman Takano, for filling in for me. I had a constituent who was testifying in a Transportation and Infrastructure Committee hearing who I wanted to be able to introduce. So I am back again, and with there being no further questions for our VSO colleagues, we will immediately begin hearing from our witnesses from the Department of Veteran Affairs. And again, I thank very much the VSO panel for being here. Today on our third panel, we are joined by Dr. Clifford Smith, the Director of Analytics, Innovations, and Collaborations at the Veterans Health Administration. He is accompanied by his colleague, Dr. Amanda Johnson, the Director of Women's Reproductive Health. Dr. Smith, without further ado, I turn it over to you for remarks on the bills before us today. And I just remind everybody too of the 2 to 3 second pause moment. Dr. Smith.
Good morning, Chairwoman Brownlee, Ranking Member Bergman, and other members of the committee. Thank you for inviting us to present our views on numerous bills that touch on subjects important to veterans. Joining me today is Dr. Amanda Johnson, Director of Reproductive Health. We appreciate the committee's continued interest in the important issues covered in today's agenda. While there may be technical issues as expressed in our written testimony that we would like to work with you on, VA supports several of those bills. For the other bills, in some instances, VA strongly supports the goals of the bill, but very similar efforts or programs are already underway or there are other issues that raise concerns. Of course, I won't be able to cover each bill in depth during my oral statement. Today, I would like to focus my attention on bills addressing the topic of mental health or women veterans' healthcare needs. We begin with the Women Veterans Trust Act. We believe the pilot program would duplicate existing programs that are currently performing well. There is no universal approach to the provision of residential mental health care for women veterans. Rather, the VA provides a range of residential treatment options responsive to the unique needs of the veterans we serve. The legislation mentions a transitional residence program that is part of VA's broader continuum of mental health residential rehabilitation treatment programs, which themselves are a core component of VA's continuum of care for veterans diagnosed with substance use disorders. Currently, 45 of our programs offer separate and secure units totaling over 600 beds specifically available to meet the women veterans' needs. Data suggests we have sufficient mental health residential capacity for women veterans, but we continue to look for ways to improve the care we provide. We would be glad to brief the committee on the full complement of what we are doing in this area. Next, the Protecting Moms Who Served Act. We believe this bill would duplicate VA's robust efforts. VA has built a strong maternity care coordination program to meet the needs of pregnant and postpartum veterans. VA currently has 134 maternity care coordinators throughout our system who help veterans navigate healthcare services both inside and outside of VA. This includes coordinating access to care for their other physical and mental health conditions, connecting to community resources, providing support with pregnancy loss, arranging needed care after delivery, and answering questions about billing for pregnancy care. VA currently provides education to community providers about the unique needs of women veterans, both through formal educational platforms and through outreach and participation in the Committee on Underserved Women of the American College of Obstetrician Gynecologists. Next, the Doula for VA Act of 2020. VA shares the sponsor's concerns about improving maternal health outcomes, promoting health equity, and combating racial bias in healthcare settings. To that end, VA has established a strong maternity care coordination program and supports care from certified nurse midwives and deliveries at accredited birthing centers. Experts in maternal health recognize this model of care provides safe and respectful maternity care to all women, especially women of color. Our concern about this bill is there is currently no standard credentialing, certifying, or licensing body to support doulas and ensure that they meet minimum standards of experience or training. We believe it is essential that any services provided to veterans in our care meets minimum quality and safety standards. Finally, the Pause for Veterans Therapy Act. There is no clear therapeutic benefit in providing untrained dogs to veterans. Results from a prior pilot study evaluating the training experience were equivocal. The majority of reputable service dog organizations are already provide trained service dogs at no cost to veterans. More importantly, we are concerned about gaps in the ability for VA to supervise the program. The bill does not give VA a role in determining when a service dog needs to be replaced for health or training problems, and instead leaves that decision to the service dog organization and the veteran. Suicide prevention is the highest of VA priorities, and VA is committed to exploring all opportunities that may decrease suicide rates among veterans. This includes revising the existing veterinary health insurance benefit for consideration of qualifying PTSD symptoms for mobility service dog benefits. For those bills we cannot support in the current form, I want to stress we share many of the laudable goals of those bills, and we are glad to work with the committee. This concludes my statement, Madam Chairwoman.
Thank you very much, Dr. Smith. And, as we begin questions, just the reminder of the 2 to 3 second rule. And I will now recognize myself for 5 minutes of questions. So Dr. Smith, I obviously want to talk a little bit about the Trust Act and your comments regarding the bill. I had the opportunity to see the Trust House in Boston, traveled there. I don't know if you have seen that operation or not, but from my perspective, it is a model and a model that should be replicated and followed. It's an in-resident program with compensated work therapy treatment. It's small. It builds family, it builds community, and interestingly enough, not a lot of VA facilities or I should say VA physicians across the country even know that it exists to be able to recommend this to their patients who might benefit from this. So, and I have visited multiple mixed gender units and the sort of the separate and secure units that you speak about. This, in my opinion, leads to women to be very isolated from their peers, because typically, it'll be 80% men and 20% women. And I think that's a generous breakdown. It's probably even a smaller percentage of women in these groups, at least from the facilities that I have visited and seen. I just don't think that is necessarily conducive to, to full recovery. So, so my first question really to you is, how does the VA support women in these in-resident programs who don't feel safe in a mixed gender setting? So that's my first question.
And thank you for that question, Congresswoman. How we would approach that is by seeking input from the veteran to meet their needs. And if their need is for a gender-specific facility, VA does have access to those. They are not always located in the same state. We do provide women's services in every VISN, But for our highly specialized care, women only, there are a series of those around the country that we would work with that veteran to enroll them into that program. There are specific concerns we have with the environment of care in regards to women. And if Dr. Johnson would like to comment on that aspect.
Thank you, Dr. Smith, and thank you for the interest of the committee. Absolutely, we do have standards for environment of care, really wanting to make sure that the care that our veterans receive is in environments where they feel safe, where they feel that they have their privacy respected, and they can receive care with the dignity and respect that they absolutely deserve. We have clear guidelines for what that environment of care should look like, and we also participate in what is called environment of care rounds at each facility, looking at both outpatient and inpatient settings, including mental health settings, to determine that everything that should be in place for veterans can be in place. Is there room for improvement? Always, always. And I would echo what Dr. Smith said about wanting to make sure that we get feedback from veterans and have processes in place to get feedback so that we can make the necessary adjustments to care.
So then, do you have a official protocol to inquire with women patients who are in this separate and secure environment to determine that they are satisfied and they feel all of the protocols that you just talked about in terms of safety and so forth? My question is there a direct protocol to be constantly inquiring with the women patients that they feel safe and secure?
Thank you for that. Absolutely. Initially, enrollment into the residential program typically is going to begin with a conversation between the veteran's provider, their individual provider, and that veteran. So they would be able to identify the program that is the best match. But then during the program, the veteran has the ability to design the treatment around their needs. And if that's gender-specific groups, mixed groups, that is able to be designed with the individual.
Well, I appreciate that. I just respectfully believe that the program that I saw in Boston is a superior program from the other programs. And I'm just not quite sure why we shouldn't be diligent about trying to replicate, best practices. I think that, we should actually probably expand this a little bit more through military sexual trauma, because I think substance use and military sexual trauma and then suicide are all interrelated. And I just think for women to have their own program in a smaller environment like the Trust House, where they're really building community, and it is superior to some of these other programs, at least that I have visited. So I'd like to explore this further, and I will, but my time is up. And so thank you. And I will now recognize General Bergman for 5 minutes.
Thank you, Chairwoman. Dr. Smith, the VA's testimony on Dr. Winstrup's draft bill states that, quote, a preferred modification of the proposal would be to eliminate the current restrictions on discipline-specific requirements for leadership positions within the Undersecretary of Health's office, if you will, end quote. Would you be willing to, please work with the Republican subcommittee staff to provide technical assistance as we work on the actual wording of this bill?
Thank you, Congressman, and thank you for the kind words at the beginning. We absolutely would. I think that would help the VA be able to continue to increase our highly qualified clinical leaders into positions of leadership.
Okay, great, because really it's not about departments, it's about leadership, as you just stated. And we need to make sure we get the best people rotating through leadership positions, because you build your future leaders by enabling them to work under good leaders. And that's That's not science, that's art, the leadership and management of organizations. I'd like to spend the rest of my time here discussing the Sergeant Ketchum Rural Veterans Mental Health Act of 2021. Basically, as it boils down to what is rural America, what is remote America, suburban, urban. You know, certainly don't have to tell you, Dr. Smith, just how isolated the veterans in the UP are. It matters how we refer to them and the challenges that they face. When examining this bill, I came across the rural urban commuting area system that VA's Office of Rural Health has adopted from the Department of Agriculture and the Department of Health and Human Services to define urban, rural, and highly rural area. That's kind of like calling the UP highly cold. Okay, we got that. Does it get extremely cold? Yes. Anyway, I think those definitions are overly complicated and miss the mark. The UP, for example, is more than just highly rural. It's remote. That is how VA should categorize it, and the many other remote areas in our country where we have veterans in need of services. I'd like to work with the department on that. And, you know, for example, we've seen during COVID tremendously positive advances in the delivery of health, telehealth, because we couldn't go out. And both providers and patients have benefited from the relaxing of regulations, the reimbursement for healthcare providers through telehealth. Now we have to have the broadband infrastructure necessary, that backbone, so that we could deliver that in places like the UP in Northern Michigan and others. So this is part of, I believe, a bigger package that's going to tie into one of the best things, the most important bills that the federal government will pass since they brought electricity to the farms in the electrification of rural America in 1938. It was a one-time deal to build out the electricity. Co-ops took it over. And this is a one-time build out for the broadband that we're all going to benefit from, especially veterans and people who live in remote areas. And that's a long way of asking, would you, as the department, be willing to work with us as we develop if you will, the priorities for this, and really show that as we deliver remote healthcare and rural healthcare to veterans, that it's going to basically advantage everyone in the country, not just those rural and remote, because of what we advanced through veterans' efforts. Are you willing to work with us on that?
Thank you, sir. Absolutely. As you know, rural mental health is my passion. That's why I live here. I love this district. I love this VA. Just last month alone, VA completed over 551,000 in-home video appointments just in mental health with veterans. Many of those into rural communities where travel, transportation, weather is a problem. We are absolutely committed to rural mental health care and rural health care overall.
Yeah, and you know, my earlier comments at the front end when I talked to Chairwoman Brownlee about maybe going snowmobile and golfing and all at the same time, there are places, and you know this, that in the wintertime, we may only be able to access a veteran's home via snowmobile. That's serious stuff. And that there's no, levity in that. That's just the reality of where we live. With that, I yield back, Chairwoman Brownlee.
Thank you, General Bergman. And I now recognize Chairman Takano for 5 minutes of questioning.
Well, thank you. Well, Dr. Smith, I know the American Jobs Plan has robust provision to expand rural broadband, which will in turn help the VA. Am I correct in that?
I would not be able to speak to that. Sorry.
I believe it does, but I'll be making that point later. I want to ask you, I want to express my disappointment that VA does not support expanding the Allied program to Korean Vietnam veterans. In your testimony, you cite cost as the concern. VA also says it has, quote, concerns about full equity, end quote, and that quote, the legislation must be viewed in the context of numerous other allies that have supported the United States during conflicts, end quote. Well, while I agree other allies are deserving of access to this program, why would others' exclusion be the reason to not let anyone in? These veterans are getting old. They're in their 70s. They've waited decades for healthcare appropriate to their needs. Why can't VA comment on just this bill intended for these Korean American allies who are now citizens, and then work with us to address the other allies separately?
Thank you for that question, sir. First, let me start with, let's set cost aside. That is not our primary concern or a concern. At the $41 million that was cited, potential with 3,000 Korean citizens now, that's not the primary driver. What our concern is regards equity. We have American citizens who fought for America, who are priority group 8 currently, who are not able to have health care. So we want to be careful and mindful that as we seek to expand our eligibility criteria to include those from the Korean Army who served, that we are also looking at consideration of those that are American citizens who have served and are not eligible to have health care.
I hear you. I hear you. And we are talking about we're talking about American citizens as well, right? We're not talking past each other, that these are naturalized.
Correct. My
right?
apologies.
Right. So we're not talking about Koreans, we're talking about Korean Americans.
Those who have attained citizenship, correct.
Right. And I realize there may be some mismatch on the category 8 that you're talking about. And maybe there's a way for us to adjust the language so that we're not denying, creating a difference between naturalized citizens who served in the ROK versus those citizens that fought for the American military. Your testimony also says that VA is concerned because the bill does not prescribe VA's means of determining proof of service from Korea. I'd like to point out that neither the original 1958 nor 1976 authorizing laws prescribe the documentation VA should use to verify service. Now, I understand that VA mainly uses certificates of British and French war pensions as proof of service, but many Czech and Polish beneficiaries didn't receive a war pension, and yet they still can enroll in VHA. We understand Canadian veterans can be verified eligible at a VA medical facility just by having the facility call the Veterans Affairs Canada. Can VA not determine its own proof of service for Korean American veterans? And why would VA prefer Congress to prescribe it?
I believe, sir, VA would like to follow what is in the current Section 109 language, where verification has to be identified.
All right. Well, I'm just what I understand from the objections is that VA would prefer Congress to prescribe it. I'm just pointing out the different ways in which veterans from other allies in Europe and Canada are able to be verified, and I hope that you'll take that back for your consideration as well.
Thank you, sir.
All right, Ms. Brownlee, I yield back.
Thank you, Mr. Chairman. And Ms. Rodawagan, I recognize you for 5 minutes of questions.
Thank you, Chairwoman Brownlee. Welcome to our second panel. I want to continue my line of questioning on the Women Veterans Trust Act. Dr. Smith, has VA evaluated utilization, satisfaction, and outcomes for women veterans seeking residential or outpatient care in single gender and mixed gender settings? And if so, did those evaluations show any key differences between the two settings? If not, why not?
Thank you for that question, Congresswoman. In part, I would like to take that back for the record because I know VA does have lots of data and information, and I would want to be very precise in that response. I am aware Currently, there is one project underway in Seattle that is looking at a gender-specific women veterans recovery group, 14-week model, and that outcome and results will be available later this spring. As regards to satisfaction, there are processes the VA uses for attaining veteran satisfaction. And other programs that look at treatment delivery. So we can get back with you in the specifics on that question.
Thank you, Dr. Smith. And I think I have a little bit of time, but continuing on, Dr. Smith, when single gender treatment settings are offered to women veterans, how often do women veterans opt into them?
My apologies, I would not know a specific number. We do have a number of gender-specific programs, like in substance use disorder, one in Cleveland, one in Coatesville. We have a number that are comorbid combined, PTSD and substance use disorder in Milwaukee, Boston, as Congresswoman Brownlee had observed, and in West LA. But I would not know the specific acceptance rate into those versus a mixed program or one of the other variations.
Thank you, Dr. Smith. I yield back my time, Chairwoman Brownlee.
Thank you, Ms. Radewagen, and I now recognize Ms. Underwood for 5 minutes of questioning.
Well, thank you, Madam Chair, and thank you again for including the bipartisan legislation we introduced together in today's hearing. The Protecting Moms Who Served Act, which I introduced with Chairwoman Brownlee, Representatives Gus Bilirakis and Brian Fitzpatrick, and many members of this subcommittee, would make critical investments in preventing maternal mortality and morbidity among veterans. I am proud to have the support of VSOs like the ones testifying today, and I ask unanimous consent to submit for the record a letter signed by 35 organizations in support of the Protecting Moms Who Served Act. Madam Chair, I ask unanimous consent.
Absolutely, yes.
Okay. Thank you so much, Madam Chair. In November 2020, the VA made several updates to the VHA directive that outlines the VA's maternal health care and coordination programs. One significant focus was the heightened emphasis on care for pregnant veterans with mental health diagnoses. Dr. Johnson, if a pregnant or postpartum veteran displays warning signs of a maternal mental health condition, can you describe the support that would be available through the VA's maternity care benefits?
Yes, thank you very much. I appreciate your question, and I very much appreciate everything that you're doing in this area. It's much appreciated. So if a woman veteran who is receiving the maternity care benefit, so getting her care through VA, she is likely getting her care, maternity care in the community, and continue to get the rest of her care within the VA facilities where she is served. So when she describes a mental health condition, then it's her maternity care coordinator who's usually that point of contact, that initial point of contact. It's not always the case. We know our maternity care coordinators have 4 times at a minimum that they're contacting that veteran during the maternity care, and that can be sort of tailored to the particular veteran. So it may be the maternity care coordinator who's the point of contact. And if that's the case, then typically what the maternity care coordinator will do will get that veteran into care. So communicate with the primary care team, the PAC team. So the primary team is aware. We'll communicate with the maternity care provider in the community, and then also with the mental health team at the facility. Sometimes there are resources that may be where the veteran might be better served in the community related to parenting, maternal health, breastfeeding, but VA is really good at mental health services, particularly for MST, PTSD, and understands that care in a really, I think, very positive way. So to answer your question, there are many ways that might happen. Primarily, it's through the maternity care coordinators with the goal of really ensuring that all the people who are involved in that woman's care, in that veteran's care, are aware of the situation. Now, the veteran might contact her primary care provider first. And again, it's going to be
comprehensive. So my
coordination, right.
My Protecting Moms Who Served Act would codify the VA's maternity care coordination programs, including the mental health care services that veterans with maternal, mental, and behavioral health conditions depend on. The updated VHA Maternal Health Care Coordination Directive also features an added emphasis on community partnerships to expand access to programs like parenting, as you mentioned, and lactation support groups and education classes. These programs underscore that maternal health outcomes are determined not only by the clinical care that a veteran receives, but also social determinants of health, from access to housing and nutrition to wraparound supports provided by community-based organizations. Dr. Johnson, can you describe how the VA's maternity care programs address both the clinical and non-clinical needs of veterans during and after their pregnancies?
Right. I think that's a very good point. And I think the point is not just that, there are additional supports that are needed during pregnancy and the postpartum period beyond clinical support. It's that psychosocial support, including housing, lactation. We actually have a few different ways that we support veterans. We support veterans within VA through items like prosthetic items like breast pumps and nursing bras and belly bands, things that veterans might need and might not have access to. Those come to our veterans. We also provide parenting classes that are directed specifically to veterans. It's something called the STARE program. But we also have connections, and the maternity care coordinators are really the folks who are sort of the boots on the ground, who are familiar with both what's available within VA and also within a particular community, like for instance, the local La Leche League or the Women and Infant Children's Program or WIC office, so that veterans can get connected to resources that come primarily through VA, but also through community resources. And that is part of our maternity care training, the training that we give for all of our maternity care coordinators. It's also part of our electronic health record, so that there's prompts.
Well, the investments included in this bill will ensure our veterans receive the maternal health care and support that they need and deserve. I look forward to working with the chairwoman and my Democratic and Republican colleagues on this subcommittee to advance this legislation forward and save veteran lives. Thank you, Madam Chair, and thank you to our witnesses for being with us today. I yield back.
Thank you.
Thank you, Ms. Underwood. And I want to thank both doctors, Dr. Smith and Dr. Johnson, for participating in today's hearing. I think, before you leave the panel, I just wanted to say a few things before you leave. And that is to say, I think that like Ms. Underwood's bill and all the other bills that have been presented here today are, I think, very good bills, needed bills that I think that we collectively, can be working on together to actually move these policies forward. And I hope very much that, that is your intention and your attitude towards this, is that these are all workable bills. And this hearing today is the first step in a process. We haven't gotten to a markup stage yet, but when we do, between now and then, there's work to be done. And I hope that you will work with each of the members and myself and Chairman Takano as well. And I just, before you leave, just on the going back to the Trust Act for just a minute, I had during our interchange, I had someone from a VSO text me that said, the text to me, and I just want to read it to you. It says, I had a member just 3 weeks ago forced to sit in a hallway in a gown while men walked by her and stared at her, even though she asked to be in a separate room. Their response, meaning the VA's response, was, quote, "You served in the military, so you should be used to this," unquote. So I'm not saying here that this is happening in every single facility, but in some of these facilities that I have seen, it just is. I think all of the attributes of being, safe, and rooms are designed so that patients can't hurt themselves, and all those things. I think that's all there and included. But I just am, I've seen other women walking through the facility, not this story specifically, but you can sort of sense a level of fear on their face. So I just, I think we need to push harder to really understand. I mean, I don't know if we really have any true data in comparison of, women in these, with a couple of beds in the mix with a lot of men, compared to what I believe is a model and best practices, the trust house. But I think that, I think that is valuable enough. And again, I hope you will, like with all of the bills, I hope you will work with me on this to get to a place where we can, move this concept forward. So again, I thank you for being here and participating today. And before I close this hearing out, I'll make a few brief remarks, but I'll first ask General Bergman whether he'd like to say anything before we conclude in today's proceedings. General?
Thanks, Chairwoman. Very simply, thank you to all for your very proactive, thoughtful engagement. This allows us, as the House Committee on Veterans Affairs, to make wise decisions as we interact with the Veterans Administration. So thank you for your time. Thank you.
Thank you, General. And again, I think it was a very productive conversation today. We didn't really have a chance to drill down in detail on some of the bills, but I will tell you I'm very familiar with all of the bills and think that the intention for all of them is good, and I hope that we can move forward. So I thank all of our witnesses today for their expertise, and certainly my colleagues for their interest. And without objection, that concludes today's hearing. And all members will have 5 legislative days to revise and extend their remarks and include extraneous material. And with that, this hearing is now adjourned. Thank you.
Thank you.